Welcome, and thanks for taking the time to view my presentation. Firstly, I'd like to thank my advisor and mentor, Dr. Kenny Lamb. He has been amazing throughout this entire process, and I would have never made it without his thoughtful guidance. During this presentation, I will be discussing the exploratory case study of a patient I treated who suffered from Parsonage-Turner syndrome, or PTS. Let's discuss some background information pertaining to this condition. PTS has been around a long time, and unfortunately has been known by many names, such as brachial neuritis and neuralgic amyotrophy. Physicians Parsonage and Turner identified and named PTS in 1948, although similar clinical conditions had been described previously in the literature since as early as 1887. The plethora of appellations for this condition lends itself to the general lack of understanding concerning the pathogenic process. The precise cause is unknown, however, it has been attributed to viral infections, autoimmune processes such as those following immunizations, hereditary gene mutation, post-surgical procedures, and also following musculoskeletal injury. This condition causes pain in its early stages, accompanied by paralysis, and then as the syndrome progresses, the patient experiences atrophy of the musculature innervated by the involved nerve. Therefore, the name Parsonage syndrome provides the advantage of referring to a well-recognized and identified clinical entity without addressing the issues associated with the poorly understood pathogenic process. Arriving at a diagnosis can be further complicated by its symptomatology and significant crossover with other conditions, such as cervical radiculopathy, rotator cuff or labral pathologies, or brachial plexus palsy. The patient in this case study was a 25-year-old male, second lieutenant in the United States Marine Corps. He reported to the athletic training facility where I work, complaining of shoulder weakness and loss of muscle mass in his right shoulder. He believed this process began after a brief bout of intense shoulder pain he experienced shortly following the administration of immunizations at the previous training installation approximately 63 days prior. While gathering his history, he reported that 7 days after receiving his pre-training vaccinations, which I consider day 0, he experienced intense pain in a V-shape around the lateral aspect of the right shoulder while standing in formation. He reported that the pain started dull around a 1 out of 10 on the visual analog scale, then suddenly increased to a 7 out of 10 over a 30-minute period. That 7 out of 10 pain lasted a day and a half, and then he experienced immediate shoulder weakness. On day 21, he noticed significant atrophy of the deltoid musculature. He was able to complete that bout of training, which lasted another 42 days, before reporting to the athletic training clinic for evaluation. Inspection revealed gross atrophy and complete absence of the right deltoid musculature, as well as significant shoulder weakness and compensatory action during strength testing. He relied greatly on surrounding musculature like the upper trapezius during examination. Any request to perform active shoulder movement, such as flexion, scaption, abduction, or extension, caused significant shrugging and side bending, as the patient could not lift the shoulder off his body well. When the arm was passively taken into these ranges, the patient was unable to hold and stabilize the arm on his own. This is a picture that was taken a few months after his initial evaluation. As you can see, the right deltoid musculature has atrophied significantly. This is a right-hand dominant individual that had little to no strength in his dominant shoulder. There also was a mild anterior scapular tilt, and due to disuse, there were scapulohumeral rhythm deficits that were also addressed during his rehabilitative process. Manual muscle testing found significant reductions in strength during flexion, scaption, external rotation, and extension. The strength at the elbow, wrist, and hand was normal and equal bilaterally. Special testing assessing the rotator cuff musculature, glenohumeral, ligamentous, or cartilaginous involvement, such as empty can, O'Brien, Hawkins-Kennedy, Clunk grind, and anterior-posterior apprehension were all negative, as well as tests evaluating for cervical radiculopathy, cervical compression or distraction, and thoracic outlet syndrome, such as Addison, Allen, Sperling's, and cervical distraction tests. Upper extremity sensation and dermatomes were also within normal limits. Since the initial evaluation seemed otherwise unremarkable, I referred the patient to the supervising physician, who ordered radiographs. Radiographic imaging showed no abnormality of the cervical spine or glenohumeral articulation, but noted deltoid atrophy with a diffuse T2 hyperintense signal without fatty infiltration, which the radiologist attributed to subacute denervation. The patient was ruled out of military training due to insufficient shoulder strength and referred to a neurologist. As PTS presents with shoulder pain, weakness, and atrophy, one can appreciate how initially this may be a difficult clinical presentation to discern amongst many more common musculoskeletal and neuromuscular issues, such as cervical radiculopathy or brachial plexus palsy, also known as backpack palsy. The most commonly misapplied diagnosis is cervical radiculopathy. The pain associated with PTS often appears radicular-like, but unlike CR, the pain is rarely positional. Sperling's maneuver is usually negative, and sensory changes do not follow a dermatomal pattern. The sensory and motor deficits are metameric, and pain may persist much longer than patients suffering from PTS. Symptoms of CR are typically exacerbated with neck movement, while symptoms of PTS are not. Additionally, progressive strength loss, as neck motion improves and pain decreases, is a sign that further investigation is required, as this is atypical in patients suffering from CR. Brachial plexus palsy is another potentially confusing differential diagnosis. BPP is a debilitating injury that presents similarly to PTS, with unilateral shoulder pain, muscular weakness, or diathesias. It has been well documented in athletics, but it is also associated with heavy load carriage activities, and as such, most reported cases occur in military personnel. That said, the diagnosis of PTS is based upon the presence of at least two of the three fundamental symptoms: pain, paresis, and amyotrophy, and the inclusion of EMG confirmation can be especially helpful. In the week following the examination, magnetic resonance imaging, both motor and sensory nerve conduction studies, and an electromyographic study were completed. The MRI and NCSs were normal. However, the intramuscular EMG discovered abnormal spontaneous activity in the right deltoid and teres minor, as well as a normal interference pattern in the right deltoid. The patient's neurologist elaborated on the EMG summary, stating these results were clinically meaningful when conjoined with the patient's history and clinical examination. The EMG was used to determine the injured aspect of the brachial plexus and to evaluate the commonalities between its findings and the patient's clinical presentation. The abnormal interference pattern identified a decrease in neurological involvement and accounts for the muscular wasting. Also, there was an increase in spontaneous activity due to the acute axonal damage. Acute axonal damage is determined histopathologically by the extent of axonal loss relative to the normal appearing white matter. It was explained that if active needles were placed into healthy muscles, there would be no spontaneous activity. However, unhealthy muscles respond spontaneously when stimulus is applied. The degree of abnormal muscle membrane spontaneity, or essentially instability, is believed to reveal the ongoing disease activity. This aspect of ongoing axonal damage in patients with PTS is also identified alongside a normal motor unit action potential. But as the syndrome progresses, changes in the MUAP will most likely be observed. The ruling out of cervical involvement in the EMG results led to a diagnosis of PTS. Following the diagnosis, several periods of communication between the supervising physician, neurologist, and myself ensued. We discussed potential for recovery and overall prognosis, and then I presented a plan for judicious therapeutic progression. The neurologist requested regular progress updates and an EMG study at 365 days post-painful episode. In the interim, the patient was placed in my care. The location where I work is a stage of training that is mandatory for Marine Corps officers. It requires intense bouts of physical activities such as martial arts training, obstacle courses, and forced marches with loads sometimes greater than 100 pounds. My main goal for treatment was to discern whether or not the patient could remain as a Marine Corps officer and then adequately prepare him for training. In the management of this condition, there are steps to be taken to decrease a patient's pain, assist in maintaining range of motion, and safely address the strength deficits that have occurred. Treatment of PTS is non-operative and typically involves analgesic medication and other forms of pain management coupled with physical therapy. Pain can be treated with non-steroidal anti-inflammatory drugs and narcotics. There have been no conclusive reports that physical therapy improves time to functional recovery. However, it does play an integral role in the treatment of this condition. With such a weakness of the musculature that provides stability and function to the glenohumeral and scapulothoracic articulations, the potential for injury during even activities required during daily life events is substantial. While the long-term prognosis of PTS is good, it can take several years before motor recovery occurs, and then the patient will battle with regaining previous strength levels. Generally, there is full motor recovery in approximately 36 patients at 1 year, 75% of patients at 2 years, and 89% of patients at 3 years. Commonly, patients with severe initial symptoms, such as increased intensity or duration of pain, will be more likely to have an extended time until symptom resolution. With the lack of understanding associated with this condition, and no other case studies similar to this patient to refer to, I implemented a judicious return to activity dictated by the patient's ability to demonstrate control while incorporating feedback from the neurologist. My primary focus was to protect against secondary injuries such as pathologies or rotator cuff tendinopathies during rehabilitation. Initially, I used functional electrical stimulation, or FES, in conjunction with therapeutic exercise. His ability to abduct the arm is where he had the greatest difficulty, so we addressed this with FES. During the FES treatment, the patient was seated in a supported upright position. A semi-elastic bandage was wrapped around the arm to create resistance for an isometric contraction. One stimulation pad was placed at the origin of the middle deltoid and the second at the deltoid on the humerus. An alternating or rushing current was used in a 10-10-5 regimen, meaning the stimulus was applied for 10 seconds and then cycled off for 10 seconds, using a duty cycle of 50%, and this was repeated for 5 minutes. During the FES, the patient was asked to contract with the stimulus, and as his resistance to fatigue improved, the treatment duration was incrementally increased to 10 minutes. The patient had very little control in early stages, so tactile and verbal feedback was used during all exercises to stimulate the patient's ability to generate and control his movement. Isometric and isotonic exercises targeting the rotator cuff musculature and mid-back musculature were implemented while maintaining the shoulder in a neutral position in the early months. The compensation during active shoulder motion was addressed through both active and active-assisted exercises in gravity-lessened positions. Throughout his rehabilitation, the patient had phone consults and with the neurologist and in-office visits for physical exams. The neurologist discussed his progress with me and supported a program aimed at further challenging the patient in order to build strength. As time passed, the neurologist felt that reinnervation was occurring due to the positive progression in motor control. The exercises progressed in difficulty regarding the involvement of gravity, level of resistance, or challenging the base of stability. As his compensation lessened and he was able to perform against greater resistance, the treatment protocol was steadily progressed to further challenge him, resulting in strength gains. Additionally, treatment began mimicking the training demands the patient would eventually face, such as pull-ups, rope climbs, and ground fighting with other Marines. The patient suffered from the idiopathic form of PTS, likely caused from the immunizations he received. This form of PTS has a minimum estimated incidence of 2 to 4 cases per 100,000 individuals per year. The median age of onset of this form of PTS is early in the 4th decade, which made this case presentation atypical. However, the patient is male, and the incidence of PTS is higher in males, ranging from 2 to 1 to 11.5 to 1 as compared to females. One potential cause for this difference lies in those that are particularly susceptible to contagions. Military personnel receive a plethora of immunizations when leaving for or arriving at military training installations around the world, as contagious illnesses represent one of the most imminent threats to operations. With this in mind, currently, women account for only 15.3% of active duty personnel in the United States military. Additionally, approximately 3% of individuals experience symptoms bilaterally. The patient resided with the majority, presenting with unilateral symptoms. Though his symptoms arose in his right shoulder, and he is right-handed, it does not appear that handedness is a significant factor. After 358 days of intense rehabilitation, the patient demonstrated that while the deltoid group was not equal in girth, he had made substantial strength gains in the area and other supporting musculature. In comparison to the initial EMG study, the final summary showed decreases in spontaneous muscle activity and increases in the MUAP, consistent with known timelines associated with axonal damage and the neurogenic process. A final evaluation by myself revealed little to no compensation during shoulder flexion, scaption, abduction, or extension, and the patient was able to achieve the full arc of shoulder abduction. Thus, he was able to achieve a first-class score on both his physical fitness and combat fitness tests. However, the patient reported a continued perception of general weakness and inability, as well as demonstrated compensatory actions when ground fighting with fellow Marines. Following recommendations from myself and the supervising physician, conditions were put in place by the commanding officer to safeguard the patient against further injury, to include no martial arts training, continued rehabilitation in order to address his residual weakness, and periodic progress updates to the supervising physician. The patient was cleared to begin training and completed training 6 months later, assigned the military occupational specialty of amphibious assault vehicle officer. Parsonage-Turner syndrome is an infrequent but not rare neuromuscular anomaly, and therefore clinicians operating within orthopedics should be aware of its clinical presentation, especially in patients complaining of pain and weakness in the shoulder and scapular belt. This diagnosis should be contemplated whenever there is pain, paresis, and amyotrophy of the shoulder girdle and/or upper extremity. The diagnosis is largely based upon the existence of at least two of the three fundamental symptoms and should be further confirmed by EMG examination. The diagnosis of PTS can be a source of angst for both the patient and clinician. This condition is not only debilitating for the patient, the clinical presentation may mirror other pathologies, which makes arriving at an accurate diagnosis difficult. The purpose of this case study is to illuminate the subtle clinical signs and symptoms of PTS when they initially present to aid athletic trainers and other sports medicine clinicians in better understanding the implications of the diagnosis. Since PTS has a debilitating symptom arrangement, early recognition, and the ability to obtain a thorough history while constructing a timeline of the symptomatology hopefully illuminates a proper course of action, in hopes of avoiding unnecessary examinations and further testing, which may cause pain or require exploratory procedures. Further research on this topic should be conducted in order to increase awareness within the sports medicine community. I just want to say thank you for taking the time to view my presentation, and here are my references.